Dear ESTS members and webinar attendees, my name is Lieve de Piepere. I'm member of the ESTS Learning Affairs Committee and your webinar coordinator and moderator for today. This is the second webinar in the 2019-2020 series with over 220 people registered today. Our topic today is about the anterior mediastinal masses and the subxiphoidal approach. Therefore, I am very proud to introduce you to Dr. Zielinski from Zakopane, Poland, as a guest speaker. He's a well-known and rewarded expert in the surgical treatment of myasthenia gravis and anterior mediastinal masses, with a special interest in minimally invasive approaches. I believe this will be a very interactive and a high-level webinar again. Please, Dr. Zielinski, the stage is yours.
Thank you very much for this kind introduction and for invitation. I'm very honored to be able to present our results and our approach for this interesting kind of pathology. First of all, I would like to say that I've never dreamed in the past that I will be the fan of minimally invasive approach. Transsternal approach, what was the technique I liked very much, but with time I adopted these minimally invasive techniques. I cannot see the presentation. Is it possible that
So you should share your media.
Okay.
Enable screen sharing, and then you can go to your
yeah.
Your presentation.
To nie jest to, mam nadzieję. Okay, can you see the presentation?
Not yet, no.
Yet? Oh, that's not good.
So you enable screen sharing, and then you should go to your presentation. Then it should work.
Screen sharing or share media?
Screen sharing. That's better than share media.
Should work.
In the meanwhile, we can already ask some questions to the audience if you want.
Yeah. Do you see the presentation?
Not yet, no.
W ogóle nie widzą w ogóle ich. To jest ten, czy ten? Ale żeby oni w ogóle to widzieli. What about now? Do you see it?
Not yet, no. It worked last Friday for the audience. So we tried this all over and it was all fine. So I don't know where the problem is. So if you click on enable screen sharing and then the total screen share, you should be able to do it. If you then go to your presentation. Maybe in the meanwhile for the
you don't see it?
No, not yet. No.
Well, I'm very sorry, but we must fix it.
That's no problem. In the meanwhile, for the audience, I will already ask them 2 questions you prepared for them.
Yes.
Yeah, now it's coming. Perfect. And then we open the presentation. Yeah.
So you can see the presentation now.
Now we can perfectly see it, yes.
Okay. So the short repetition from the history. Minimally invasive approaches were in the modern shape were introduced in the 1990s. It were unilateral right VATS. One of the first, or the first, was Sugar Baker. On the left, Landrenault and colleagues. Robotic Yoshino, 2001. Transcervical, a bit earlier. This extended transcervical technique is described by Cooper. It was 1988. And combined approaches, bilateral VATS plus transcervical, the technique called weighted, was described by Italian Novellino, 1994. And subxiphoid plus transcervical by Ito from Japan, 1997. It was in Japanese journal and described in Japanese, which I learned quite recently. And of course, I couldn't read it, but I could see some photographs which illustrated this technique, and the technique was very interesting combination of transcervical plus subxiphoid. Our team started from 2000, and our technique was transcervical subxiphoid bilateral VAT, single port VAT on each side, with elevation of the sternum from the side of manubrium and the lower angle. This was our initial technique, and we used it for several years. Then we started to make it a bit less invasive by elimination of the transcervical incision. So our next technique was subxiphoid right VATS. And the next was subxiphoid bilateral VATS. And this technique became our standard for about 10 years. This is our original technique. The video was made 15 years ago. It was combination of transcervical plus subxiphoid with double elevation of the sternum, as you see. Mm-hmm. This, and maybe we come to the questions now. Lieven, what do you think about it?
Yeah, so I already published the two first questions. The first one was, what operative approach do you use for the mediastinal procedures? And the second one was, how many operations of the mediastinal pathology do you perform per year?
Yeah, okay.
Already quite some people answered and voted. And I think you cannot see it right now, so I'll tell you.
Yes.
Question: what operative approach? Let's say that about half of the patients, half of the people are answering VATS approach, so that is 53% VATS, and for the rest we have thoracotomy in 15%, cervical incision in about 15%, full median sternotomy in 10%, and subxiphoid in 7%. So people are still voting. VATS is coming to 60%. I adapted it that people can also vote for different things. So it can be that you do VATS, that you also do median sternotomy. So both are possible. So the majority is VATS, and then comes sternotomy, then thoracotomy, and the cervical incision and subxiphoid are minority.
I'm not surprised.
Okay, and then for the second question, how many operations of the mediastinal pathology do you perform per year? This is for 45% between 1 and 25, and also 45% between 25 and 50. and only a minority is doing more than 50 cases per year.
Well, this is also not surprising, because myasthenia is a rare disease, and the thymoma is a rare kind of tumor, and all other types of the anterior mediastinum are even less common. So these results are expressed, I think, the experience of most of people.
Okay. Do you want to go to the other questions, or?
So maybe I will talk a bit about the role of ectopic thymic foci, because this is on this figure. You can see the numbers. We tried to study the specimen in case of myasthenia without thymoma. We divided the area we dissected in five pieces. One is cervical area, the other is perithymic area, aortopulmonary window, aortocaval, which is more or less paratracheal space, and right and left pericardial diaphragmatic areas. As you see, the ectopic foci were found everywhere, but the area in which they were found most frequently were the perithymic and aortopulmonary window. It shows the necessity of removal of the fatty tissue from these areas, because the ectopic foci are not visible by eye. They are visible by the microscope only. So you must dissect the fatty tissue from all these areas to remove all these ectopic foci. But if you do it extensively and carefully, your results are better in terms of complete remission rates. We studied this problem comparing our previous technique, which was the basic thymectomy through median sternotomy, and two other techniques, extended thymectomy, performed by complete sternotomy, and the transcervical subxiphoid VATS, maximal thymectomy. As you see, the results of these two extensive techniques were much better than in case of basic thymectomy. It was the difference was significant. It was a retrospective study, but the difference was significant. So it showed the advantage of removal of the fatty tissue in extensive way. The other interesting finding, I think, is that even if you find the ectopic foci in many areas, like in case of transsternal, even in 5 areas or 4 areas, you can still expect a good complete remission rate if the dissection you performed was complete and extensive. So this was showed by for 2 different techniques, extended transsternal and transcervical subxiphoid VATS. In both cases, there was no difference of complete remission rate if there were the ectopic foci in many locations, or if there was no ectopic foci found at all. It means that if you achieve proper extensiveness of thymectomy, you can expect favorable later outcome even in patients with multiple ectopic thymic foci. Our results were contrary to the results of Ashur and colleagues from Saudi Arabia, published before our study. The message is that in case of myasthenia without thymoma, you must be very extensive. The thymectomy must be very extensive. Is there any question about that, or I can follow?
For the moment, we don't have any questions, but of course, people are encouraged to ask questions. You can do this in the right sidebar, in the questions bar, and then I'll ask them to you. But for the moment, the audience doesn't have any questions.
Okay, because I wonder if it was clear what I said.
I think so. We don't have any questions. To me, it was clear.
Okay, thank you. In 2013, we started a prospective randomized our institutional trial comparing subxiphoid bilateral VATS, extended thymectomy, and similar technique, but with the use of subcostal ports versus intercostal ports. So this is the technique showing how we introduce the intercostal ports. So under control of thoracoscope, we introduced intercostal port or subcostal port. The introduction of subcostal port is a bit more difficult, and we undertook this study to learn if the subcostal ports, theoretically less painful, were better than intercostal. Mm-hmm. And we presented the results of this study on ESTS in Lisbon this year. But to our disappointment, we found there was no statistical differences, of results between both groups in terms of decrease of FEV of FVC and FEV1, and in regard of pain. So subcostal approach doesn't provide any advantage in comparison to the standard intercostal port. But the other interesting finding was that there was a very deep decrease of spirometric values on the first and second postoperative day. These values dropped to about 40% of the preoperative values. So this
in both groups.
It was in both groups. It was exactly the same.
Okay.
So it shows that thymectomy is not a mild procedure. On the other hand, the patient recovered very, very fast after this procedure. But it was interesting. There are almost no publications on that in the literature. How much the spirometric values decrease after thymectomy.
That's very interesting. Because we already have a question about that. With the subcostal approach, the question is you have to penetrate the diaphragmatic muscle. So
no, this is not true. We go through the insertion of the diaphragm, so we don't violate the diaphragmatic muscle.
Okay, you just go through the insertion. Did you see any postoperative hernias? Did you see any problems at the place where you put in your trocar, your subcostal trocar?
No, no. We didn't have such complications, but we had 3 hernias in the subxiphoid incision. 3 hernias for 700 operations. So not so many, but it can happen, and it happens.
Okay. And another question was, were all these patients myasthenia gravis patients, or was it also thymoma patients?
In this particular prospective study, all patients were myasthenia without thymoma.
Okay.
In 2016, we started to use another modification of the approach. It's uniportal subxiphoid approach. And overall, we operated on almost 700 patients overall, so with the use of all this technique mentioned before. For myasthenia, thymomas, and for rethymectomies after previous failure of thymectomy. We had no mortality, and morbidity was around 4% overall. And this is the next few pieces of video illustrate the technique of the uniportal thymectomy with subxiphoid incision. In this particular case, the incision was longitudinal, because the incision for this kind of operation can be longitudinal or transverse.
Okay.
In the advantage of longitudinal is that if you, for example, want to convert to sternotomy, it is easier to do that with the use of longitudinal.
Mm-hmm.
And I propose to ask the next question about the conversions, if you don't mind.
Okay. I posted them. Maybe in the meanwhile, I can ask some questions that were coming up.
Yes, sure.
So about the lung functions, did you measure the lung functions on beforehand also, the baseline lung functions in these patients in the prospective study?
You mean their spirometry?
Yeah.
No, because we had not enough time. It was impossible to perform such study, because we are kind of a referral center for the country, and the people come to us, the patients come to us from sometimes remote places. Okay. And they leave the hospital usually it is on the 5th post-operative day. So, and they never come back. So it's impossible, unfortunately. It would be interesting, but some of the people we follow up if they come.
Okay.
And they do not complain from any difficulties in breathing. So I think that the spirometry comes to the initial values, preoperative values.
Okay. I'll let you first comment on the video.
But we didn't study that.
Okay.
And so this is the technique. We elevate the sternum. So we start from the lower angle of the sternum, and then we put the second hook under the manubrium. And then we proceed with dissection. So we try to remove all the fatty tissue, starting from the epiphrenic fat pads, continuing upwards. As you see here, this is a huge tumor but operable with this particular technique, as you see.
Mm-hmm.
The visibility is very good. You can see both phrenic nerves on both sides, which is very safe for the patients, because you can be very extensive and there is no risk of injury of the nerve. In fact, we never had any injury of the nerve with use of subxiphoid technique, because we always can see the nerve very, very well, yeah. even in this uniportal technique. You see, this was the dissection of the left innominate vein. This is a maneuver which is very useful. I mean, to open the contralateral mediastinal pleura and to transfer the specimen to the contralateral pleural cavity. It makes everything easier because the tumor is not obscuring the view. Okay.
How is your patient ventilated?
The patient is usually the patient is ventilated with in this moment with the left lung. Okay. But it can be, this operation can be done. So we started with ventilation of the left lung, then we can switch to the right lung. But it is also possible to hypoventilate the patients slightly under control of anesthesiologist. Mm-hmm. And in this case, both lungs can be ventilated, but not too forcefully.
Okay.
In this particular operation, we used biclamp, bipolar coagulation. Of course, ligature, harmonic are as good as bipolar. I usually use bipolar because this is the cheapest instrument. It is multiple use. Well, it's practical for those from the countries which are not so rich. Mm-hmm. Maybe it's cheaper. And this is we follow with dissection upwards until the thyroid is visible. Maybe it will be visible in a minute. This is the moment we manage the lower thyroid veins.
Okay.
So this is almost the end of the dissection. You can see the disconnection of the specimen from the innominate vein. The left lung is ventilating, as I told you, and the specimen is put to the right pleural cavity and is removed in the bag, which is extremely important. I must stress it. This is extremely important, not to disrupt the capsule of the tumor. Mm-hmm. And to remove the specimen in the bag, because otherwise there are some local recurrences. Thymoma, very few metastasize to the distal organs, but the risk of local recurrence is real, very real. Mm-hmm. This is the dissection of the AP window. So the nodes from the AP window are removed, and you see in the bottom, you see the left vagus nerve. If you can see the phrenic nerve, the left vagus nerve, and the pulmonary artery, it means that this section is extensive enough. And the last view in the neck, the thyroid lobes, the lower poles of the thyroid are visible, as you see. It means that you remove the whole thymus. Elevation of the sternum is extremely useful for that.
Mm-hmm. Very nice and impressive video.
Is there any? Are there any questions for that part?
For sure, there are questions. Do we go to the poll first or to the questions?
Well, as you wish. You are the boss.
Well, then some questions quickly. Do you use any CO2? I don't think it's necessary.
No, no. I don't use it. This can be the alternative, of course. Mm-hmm. And many people, I am aware that many people use it. But with this particular technique, with the use of Alexis retractor, plastic retractor, and it would be impossible. Mm-hmm. With this particular devices.
Okay. Another question, do you believe you can dissect the fat in the whole cervical region without the cervical incision? I think we have seen this on the video. We have seen a thyroid, so yes, it is possible. How do you elevate the sternum? We have seen the device with the two pieces, one for the xiphoid and one for the manubrium, I think. The skin incision, horizontal or vertical? I think vertical, you told us in case you have to do a sternotomy.
Yes.
With angles, yeah.
In case I am not sure if sternotomy is not necessary, you know. If I'm sure, for example, in case of myasthenia without thymoma, I don't use vertical incision, only the transverse. Which is, I prefer transverse incision. But
do you see another scar healing? Do you see the better vision? I don't know.
Yes, it is. If you make a transverse incision and you elevate the sternum, the shape of the incision is round. The approach is like is similar to round shape, so I prefer it. But it can be done by vertical as well, as I showed.
Any differences in hernias in the transverse?
Well, all these hernias were after transverse, but with these 700 operations we did, let's say, more than 650 with transverse and less than 50 with vertical. So this comparison is not not valid.
Then a question about the angle of the scope.
Well, degrees. We usually we use the oblique 30% oblique scope. We like very much to use so-called chameleon scope, which is the wide. The range of view is very wide. This device.
Okay. And then another question: do you routinely open both mediastinal pleura? I think yes.
Yes. And I try to do it from the very beginning part of the stage of the operation.
Okay, these were the questions so far. Maybe we come to your questions then. One question was, in your opinion, what are the contraindications for minimal invasive approaches? And there, let's say 40% of people said infiltration of the vena cava superior or the endominate veins. And then 25% said a size of tumor more than 8 to 10 centimeters. And in 16%, they said after neoadjuvant therapy. And then less frequent was the size of the tumor more than 4 to 5 centimeters, or infiltration of the lung or the pericardium. So the most of the people said contraindication is infiltration of the vena cava superior or the innominate veins, followed by the size of the tumor more than 8 to 10 centimeters, and then after neoadjuvant therapy. What is your opinion about that?
Well, in my practice, I don't operate patients who have infiltration of the left innominate, although my friend from Shanghai, Professor Tan, presented a series of cases in which he resected the left innominate vein with the use of subxiphoid approach, but I never did it. I never. So this is not the absolute contraindication. In case of vena cava and in the right innominate vein, I think it is an absolute indication, contraindication for this kind of surgery. Mm-hmm. In my practice, I resected, in some patients, I resected a piece of the lung with the cut with endostapler, a piece of pericardium, and I resected huge tumors as was shown. So I hesitated for years if to start to operate on thymomas with this approach. And we started this subxiphoid transcervical approach in 2000, but we started to perform thymectomies for thymomas only in 2007, after gaining a lot of experience with this approach. So I think that sternotomy is still a good approach, in my opinion.
Okay. So then, indeed, the next question you asked to the audience was, in your opinion, what is the rate of conversions to thoracotomy or sternotomy that is acceptable? And 60% says this is between 0 and 5%, but 30% also says between 5 and 10% is acceptable. And even 7% says that it may be more than, or almost 10%, sorry, says that it may be more than 10% conversion rate. So it depends a little bit, I think, on what you tell your patient, or what is your opinion?
Well, it is, you can always try with minimally invasive approach. You can put the thoracoscope, see what is inside, and you can do sternotomy or thoracotomy. Does it mean that this is a failure? I don't think so. So in my practice, the rate is between 0 to 5%. But we are an institution which has a lot of such operations. So this is difficult to compare. We do about almost 100 operations each year for mediastinal pathology. So I think that people should not be too ambitious, I think. Mm-hmm. And it is this is not a mistake to put a thoracoscope and initially and then to convert. This is my opinion.
Okay. Then some questions came back about the sternal elevation. You already said with or showed that device. The port CO2 insufflation, we also answered that. How many tubes do you use postoperatively?
We usually put one tube to each pleural cavity.
And they come
24 or 28. 24 or 28. Now we usually put 24.
Okay, and they just come out through the subxiphoidal incision.
It depends which is the approach. If we use the subxiphoid combined with these two lateral ports, the tubes are put through these lateral ports. Mm-hmm. When it is uniportal, the tubes are put through the subxiphoid incision.
Okay, then we listen to the rest of your presentation.
I have some technical advices. So the patient can be positioned in a semilateral, lateral position, but in my opinion, the best position is supine position, because it enables approach to both pleural cavities, and you can see both phrenic nerves very easily when you use this position. So I recommend supine position for thymectomy.
Okay.
And well, I also recommend elevation of the sternum, as I said. And I also recommend the use of special stiff metallic suction tube, which is extremely useful. It helps you with dissection. So this is the instrument I found very useful.
Okay.
It's a curved instrument. And as I said, answering for the question, CO2 is alternative to elevation of the sternum.
Mm-hmm.
And as I repeat, the main advantage of subxiphoid approach is that both sides can be of the chest can be visualized.
Yep.
The other important advantage of subxiphoid is that it is less painful than intercostal incision, and it never leads to chronic postoperative pain. We never found chronic pain. No other patients complained from the pain. It is well, it is understandable, because it is this incision is made in the area where are no nerves, so no major nerves. So it is better than intercostal space.
For the positioning, there's another question here. What should we do with the head? Just straight or a bit more extension of the neck?
This is a very good question, because if you elevate the sternum, there is the risk that the patient's head will hang and the spine can be injured. So cooperation with your anesthesiologist, who puts a pillow under the back of the patient's head, is extremely important.
Okay.
Protect the spine.
Yeah.
This is the summary of advantages and disadvantages of subxiphoid VATS thymectomy. Well, we use this approach in about 80 to 90% of thymomas we operate, but not in every case. In some cases, we don't use it. So this can be called the disadvantage of subxiphoid approach, as this is the disadvantage of any other minimally invasive technique. You cannot operate on every patient with this approach. But in most of cases, you can resect the thymoma. And the other disadvantage, this is the possibility of, in comparison to our previous technique, transcervical subxiphoid, the possibility of visualization and dissection the laryngeal recurrent nerves on both sides is worse. The question is if it is so extremely important. But if we wanted to be very extensive in our resection of the tissue surrounding the thymus, we tried to visualize the nerves and to avoid injury, of course, of the nerves. And so this technique without cervical incision is worse. But the rest are, I think, advantages. So the relatively non-painful, total avoidance of risk of disruption of the sternum, visualization of the thyroid, and access to the chest wider than intercostal utility thoracotomy. This is important in case of big thymomas, which are easier removed from the chest through the subxiphoid incision than through intercostal. Mm-hmm. And well, the cosmetic result is also very good, with no scar in the neck. But the new issue emerged recently: lymph node metastasis of thymic malignancies. This is a publication of our Chinese colleagues, and they found in a very large series, typical for Chinese publications, more than 1,600 patients, they found lymph node metastasis in 35 patients. And no metastasis in type A, AB, and B1, but there were some metastases in B2, B3, and with thymic carcinoma, especially thymic carcinoma. Almost 8% of patients had metastasis. Most common in neuroendocrine thymic tumors, it means carcinoid tumors, which is a very malignant tumor, carcinoid, contrary to the bronchial carcinoid. Almost 17% of patients had metastatic nodes. Mm-hmm. It was the rate of metastasis was also different from early tumors and larger in T4 tumors, almost more than 7%. So I wondered, based on that, because I've never seen any metastatic node for any thymomas I ever operated on. So but these results showed that it is possible. If it's possible, this is the question: what if to do lymphadenectomy, and how to do lymphadenectomy? So maybe we'll ask the question now. Okay.
Okay. People are voting. In the meanwhile, we have another question from the audience. What do you think about robotics for myasthenia gravis patients and the possible advantages or disadvantages versus the Subxiphoid VATS approach? What is your opinion there?
Well, I don't have any personal experience in that because we don't have robot. It is this device is too expensive for us. Mm-hmm. But Japanese surgeon Takashi Suda described the robotic technique through subxiphoid approach in a very elegant way. In my opinion, this is a very good technique, but not better than the technique without a robot. Mm-hmm. I see any special advantages for robot. This is my opinion about that. I am strongly against the opinion that robot is something better. In my opinion, it is not.
Okay.
So this is this part. So this piece of video illustrates what we were able to do with through transcervical approach combined with subxiphoid. This is a view from the transcervical side. So, speaking frankly, this is more extensive and better, but but you must do additional incision, so it's more advanced, more invasive. But if you want to do lymphadenectomy, this is a perfect approach for lymphadenectomy.
Okay. Maybe then we come to your questions indeed.
Yes.
About the lymphadenectomy. So the first question was, do you perform mediastinal lymphadenectomy in thymomas and thymic carcinomas? 40% of the people answered only in suspicion of thymic carcinoma. 30% said, I do not perform any lymphadenectomy. And another 30% says only in stage 3 tumors.
Okay, so I congratulate the audience. People are very radical, more radical than I am. I don't do lymphadenectomy, maybe in suspicion of thymic carcinoma, which is very rare. In that case, I would think about it. But in thymomas, I never do lymphadenectomy.
Okay. And then the next question was, if you perform a lymphadenectomy, what is the extent? There 40% says the anterior mediastinum plus stations 3A, 6, and 5, and the middle mediastinum. So this is quite extensive, I think.
Yes.
33% says only the anterior mediastinum, and 23% says anterior mediastinum, 3A, 5, 6, the paratracheal nodes, and station 7. So the most extensive approach in almost 1 in 4 of the audience.
I think it means that the people are very good surgeons, very experienced, and very brave. So I congratulate the audience. I now with this approach I use without transcervical incision. I only remove the nodes if I suspect that there might be something wrong with the nodes in the anterior mediastinum 5, 6, and 3A. That's all.
Well, I must say that this was 1/4 of the audience that answered this question. So I think this is indeed the more experienced surgeons that
Yes.
answered this question. The rest, of course, I think did not do any lymphadenectomy or extended lymphadenectomy.
I think this is the emerging topic, and in the future maybe we will be more aggressive, all of us.
Mm-hmm. Do we go to the last question also? Your last question about adjuvant therapy, or is this for later on?
Well, I think yes, maybe yes. It is a good time for the question.
The question: what are indications for adjuvant chemotherapy and or radiotherapy? And there, this is quite divided. 1/3 says stage 3. 1/3 say in case of R1 or R2 resections. And then about 20% says in WHO B2 and B3 type thymomas. And then a minority of 13% says in stage 2 also.
Mm-hmm.
So 1/3 says stage 3 and 1/3 says R1 and R2 resections.
Well, my attitude towards this is that I would hesitate to refer the patient with R0 resection for stage 2.
Mm-hmm.
Stage 3, rather yes, although there are not good data for that. But I would rather advise the patient to have adjuvant radiotherapy.
Okay.
R1, R2, again, adjuvant radiotherapy.
Okay. And if you have an R0 stage 3?
Well, I would rather advise to have radiotherapy. Yes.
Okay. Okay.
This is, in my opinion, this is less role for chemo in as an adjuvant. But well, I'm not an oncologist, of course.
Okay. Okay. There's one more question for the audience. When do you take a preoperative biopsy from non-myasthenia gravis anterior mediastinal masses? So when is it necessary to do a biopsy, or do you say, okay, I see this from the imaging, this will be a thymoma, I don't need any imaging?
In two cases. In one, this is I have some doubts about the diagnosis of if it is a thymoma, to differentiate, let's say, from lymphoma.
Mm-hmm.
So in this case, I propose to do maybe parasternal mediastinotomy or VATS, depends, which is more convenient in this particular case. And in the other situation is if the tumor is, in my opinion, inoperable, and I want to refer these patients for neoadjuvant therapy.
Okay.
There are two situations. We do biopsy. Otherwise, we try to avoid biopsy.
Okay. I have another question here. Radiotherapy is local treatment in the respected area, but recurrence is regional with pearl droplets. So does it make sense to add radiotherapy or any adjuvant therapy in an R0 resection? That's why I asked at stadium 3 R0 resection, should you do any adjuvant therapy or not? So this is a bit discussed here in the audience, but as you said, it's difficult, I think, to have any evidence on that.
Yes, there are no evidence for that, and this is a controversial issue, but this is difficult to study this problem, very difficult, because most of recurrences come after years. Frank Detterbeck made an effort to calculate from several publications what is the mean time from the thymectomy for thymoma to recurrence, and his result was 7 years. So only after 7 years you can see the recurrence. So this is very difficult to study such a delayed process. And in case of the recurrences in thymomas are not similar to the recurrences in any malignancies, because this what is the mechanism of recurrence? Mainly by disruption of the capsule. I think this is probably the main prevalent mechanism. Theoretically, some pieces of the tumor can be left on the pericardium, maybe on the diaphragm. These are, I don't have evidence, but for these reasons, I think maybe radiotherapy is more effective.
Okay.
Because, but nobody can be sure about that.
No, it's an opinion. Okay. We're approaching 7 o'clock, so I'll let you come to your conclusions.
My conclusions are a repetition of what I said, that subxiphoid VATS thymectomy includes double elevation of the sternum, opening of both pleural cavities, and radical unblocked resection of the whole anterior compartment, including the thymus. This technique can replace transsternal thymectomy in 80 to 90% of thymomas. Further studies are necessary to compare a uniportal subxiphoid approach with subxiphoid bilateral intercostal or subcostal VATS approach for thymectomy, for myasthenia, or for thymomas. And if the role of mediastinal lymphadenectomy becomes established, a combination of subxiphoid plus transcervical approaches may be the optimal technique for such lymphadenectomy. Okay. This is my last conclusion, which is very early and premature, probably.
Okay. Then maybe one question to finish with. In your series, do you see leukemia in follow-up of the operated patients of thymoma?
Can you repeat it, the question?
Otherwise, you can close your screen and you can see them also yourself if you stop enable screen sharing. Yeah.
Yes. Okay. Yeah.
Then you can also see them. Yes.
Mm-hmm.
And then you should close it. But I'll repeat the question in the meanwhile. In your series, yeah,
okay.
that's it. Do you see leukemia in follow-up of operated patients of thymoma?
Which is the question? Which is? I don't see it.
So if you scroll completely up, because we all had all the other questions already, there.
Yes.
The second question you see in your series: do you see leukemia in follow-up of operated patients of thymoma? Do you see any leukemia? I don't know. Yeah.
No, I don't see it.
Have seen it before or not?
I don't see. I see some comments and questions from many friends. So I say hello to Dirk van Remdonk, to Firas Abuakar, Miguel Tede, and probably many others. I'm very maybe very happy that these people participated, but I cannot see this.
Now, maybe we close with the last question. If you ever had a problem with the phrenic nerve and you cut the phrenic nerve, do you suture it end to end, or do you let it like that?
Thanks God, I never had any problem with injury of the phrenic nerve.
And what would you do theoretically?
Difficult to say, because just to suture the nerve without microsurgery is futile effort, in my opinion.
Yeah. Okay. Thank you very much, Dr. Zielinski, for this very interactive webinar. We had a lot of questions from your side. We have a lot of questions from the audience. We had more than almost 100 people watching live and more than 200 people, 220 people registered. So a lot of them will watch this after the recording, I think. Thank you very much to the audience. Thank you very much to you.
Thank you.
I hope to see all of you back on the 16th of December for an esophageal session given by Don Lowe about the enhanced recovery after surgery in esophageal surgery. Thank you all, and see you next time. Bye.
Thank you very much. Thank you very much, and goodbye to everybody.